À l'ordre, bonjour et bienvenue à la 16e.
Good morning and welcome to our 16th meeting of the Indigenous Committee
of the Algonquin Anishinaabe Nation. Aujourd'hui, on commence notre troisième.
Today, we're beginning our third study on the administration and access for Indigenous people to uninsured health benefits.
Today, one of them is not yet online, but we're going to start the meeting with the hopes that he will join us. And then at 2 o'clock, we'll proceed to our in-camera meeting to discuss committee business. Je voudrais vous rappeler des exigences du bureau.
I'd like to remind you of the directions of our internal committee as to the use of health precautions.
Our interactions. Members or witnesses may speak in the official language of their choice. Interpretation services in English, French, and Inuktitut are available for the first part of today's meeting. Please be patient with the interpretation. There may be a delay, especially since the Inuktitut has to be translated into English first before it can be translated into French and vice versa. The interpretation button is found at the bottom of your screen in either English, French, or Inuktitut. If interpretation is lost, please inform us and we'll stop the meeting until we can rectify the problem. Before speaking, please wait until I recognize you by name. And if you are on the video conference, please click on the microphone icon to unmute yourself. When speaking, please speak slowly and clearly. And when you're not speaking, your mic should be on mute. A reminder that all comments should be addressed through the chair. We're going to start with each of the witnesses speaking for 5 minutes. The witnesses are Vice Chief David Pratt, Federation of Sovereign Indigenous Nations, appearing on behalf of the Assembly of First Nations. Vice Chief Pratt is not yet online. Secondly, we have Mr. Nathan Obed, President of the Inuit Tapiri it Kanatami, and accompanied by Mr. Pierre Lecomte, Senior Policy Advisor of the ITK as well, and also by Madame Cassidy Caron, Présidente Le Ralliement National des Métis. Given that Vice Chief Pratt is not here yet, I would ask Mr. Obed if he's ready to kick us off with a 5-minute presentation. Mr. Obed?
Nakamik, Mr. Chair, thank you very much. It's great to be here talking about such an important topic. I'm Nathan Obed. I'm the president of Inuit Tapiri Kanatami, the national representational organization for Canada's 65,000 Inuit. The majority of Inuit live in Inuit Nunangat, our homeland encompassing 51 communities across the Nunavut settlement region in the Northwest Territories, the entirety of Nunavik in northern Quebec, and the Nunatsiavut region in northern Labrador. There are many Inuit that also live in southern centers. And when it comes to the considerations for non-insured health benefits, those Inuit who live out of jurisdiction still are Indigenous peoples and still have the ability to access non-insured health benefits, but in very different ways. There are 3 points I hope you take from my presentation. First, that the majority of Inuit rely on non-insured health benefits and access a range of medically necessary healthcare products and services not otherwise provided through provincial and territorial health programs, social programs, or private insurance plans. Inuit are not a part of the Indian Act, and so the jurisdiction and the service delivery flows primarily through provinces and territories or through Inuit self-governing mechanisms, which are emerging and will continue to evolve as we are successful in achieving self-determination over the healthcare system. My second point is in relation to Inuit beneficiaries facing barriers in accessing and receiving NIHB program benefits due to the existing program structure, its restrictive policies and administrative processes. And finally, there's a clear need for the development and implementation of Inuit-specific goals and objectives to address barriers to care and to provide timely, responsive, and equitable access to NIHB by Inuit, no matter where Inuit reside. The NIHB program plays a key role in healthcare access and delivery in Inuit Nunangat, from medical transportation, pharmaceuticals, dental care, vision care, medical supplies and equipment, and other services. These healthcare products are administered and delivered to Inuit by the NIHB program, and they directly impact our health outcomes. Given the state of Inuit health and the challenges of healthcare delivery across Inuit Nunangat, it's fundamentally important that the NIHB program provide timely and accessible healthcare products and services to fully support the healthcare needs of Inuit. To this end, the program must be properly resourced, offer unique and adaptable administrative processes, and be accountable to the goal of timely access to care. A recognition and commitment that demonstrates the government's willingness and leadership to better meet the needs of Inuit, and also to be truly responsive to Inuit specific circumstances and realities, and to provide for a firm commitment on improving timely access to care are the things that we are hoping for from any improvements to the NIHB program. These changes have to be made to improve the program's approach and delivery in order to support the needs of Inuit across Inuit Nunangat. They must be clear and specific priorities that are delivered in a distinctions-based way, in a timely way, and also allow for considerations of Inuit positions in the way in which these services are considered and delivered. In conclusion, we urge the Standing Committee to seriously consider the importance of providing inclusive and Inuit-specific goals and objectives as part of its review of the NIHB program's administration and accessibility objectives. Further, to truly demonstrate a clear commitment to eliminate barriers to timely access and develop responsive processes to better meet the needs of Inuit. Thank you for the opportunity.
Thank you, President Obed. Nous irons maintenant.
We'll now go to Ms. Caron, the Métis National Council. You have 5 minutes, madam.
Tansei, thank you. Good afternoon, Chair and committee members. Thank you for the opportunity to participate in your hearing today. I am here as the president of the Métis National Council to speak to you on the administration and accessibility of non-insured health benefits for Métis people. This has been identified as a top health priority for the Métis Nation's citizens. On April 13th, 2017, the Canada Métis Nation Accord was signed by the Métis National Council, its governing members, and the Prime Minister on behalf of Canada. It recognized the Métis Nation as a distinct Indigenous nation with inherent rights and formalized the nation-to-nation, government-to-government relationship between the Métis Nation and the Government of Canada. The Métis Nation, with its own collective identity, language, and way of life, continues to advance its right to self-determination, including self-government in Canada, through democratically elected governance structures and registries. Each governing member is mandated to represent its citizens. As a constitutionally recognized Indigenous people, Métis must have the same opportunity as First Nations and Inuit to contribute to the achievement of an overall health status comparable to the Canadian population and shift the focus of health service delivery from an illness model to a prevention, wellness, and health promotion model. Métis people do not have poor health outcomes because they are Métis. Poor health outcomes are a result of oppressive policies that have effectively sought to erase or assimilate the Métis. Health is not merely the absence of disease. For the Métis Nation, it is a state of balanced and interconnected relationship between physical, mental, social, spiritual, environmental, and cultural well-being. A self-determined Métis version of the non-insured health benefits will work towards improved health and well-being for Métis citizens, families, and communities now and for future generations. It is increasingly clear that these health inequities arise from disparities in Métis social determinants of health and the processes of colonization, forced assimilation, and social exclusion. In 2013, the Health Council of Canada reported that despite significant investment to address inequities in the health status and health outcomes of Aboriginal people, the impact of these initiatives is unclear. None of the noted federal health services available to other Indigenous people are currently, nor have they ever been available to Métis people. Provincial supports and services are also not meeting the needs of Métis citizens. However, a positive example can be found in the territories. The government of the Northwest Territories Métis Health Benefits Program provides Métis with access to a range of benefits not covered by standard hospital and medical care insurance, including eligible prescription drugs, dental services, vision care, medical supplies and equipment, and medical transport and accommodation. Benefits of this nature should be available to Métis citizens across the homeland. Métis non-insured health benefits should be financially sustained by federal financial resources, coordinated with provincial authorities and private insurance providers. With secured resources, the MNC's governing members are ready to action exploration of operational and financial models responsible to the needs of Métis citizens. These actions will include feasibility analyses of benefits plans, coverage, cost-benefit analysis, burden of disease, health, and economic impact assessments. Everyone in Canada has the right to health. This right is defined and protected by international human rights treaties that Canada has ratified. The International Covenant of Economic, Social, and Cultural Rights affirms the right to enjoy the highest attainable standard of physical and mental health. In the Canadian context, the preamble to the Canada Health Act states that continued access to quality healthcare without financial or other barriers will be critical to maintaining and improving the health and well-being of Canadians. Specific to Indigenous peoples, the Truth and Reconciliation Commission calls to action number 20 calls upon the federal government to recognize, respect, and address the distinct health needs of the Métis, Inuit, and off-reserve Aboriginal peoples. These rights mean that all Indigenous people should be able to access the health and wellness programs, services, and non-insured health benefits they need when and where they need them, without suffering financial hardship or encountering anti-Indigenous racism. Many Métis cannot realize the right to health as it currently stands. In the current system, Métis are underserved and marginalized, resulting in poor health outcomes and vulnerability. The Canadian federal, provincial, territorial governments have an obligation to support the opportunity for a barrier-free, high-quality, culturally safe, and equitable health programs, services, and benefits for Métis citizens. We are working alongside the government and having conversations and hope to propose a self-determined Métis non-insured health benefits plan. The Métis Nation is committed to working with all levels of government as an equal partner to make this happen. And we look forward to actioning a Métis non-insured health benefits program. Thank you again for the opportunity to articulate the immediate health priority of the Métis Nation and express the voice of Métis citizens. And we welcome any questions you may have. Marcy.
Thank you, Ms. Caron. Vice Chief David Pratt is now with us. So, Vice Chief Pratt, you have 5 minutes to make your initial presentation.
All right. Thank you, Mr. Chair. Can you hear me all right?
Yes, we can.
All right. Good afternoon, everybody. First of all, Anin Chagwa and Tansigia to everyone. First of all, I want to acknowledge the Treaty 6 territory that I'm calling from on here today. I want to greet the members of the Standing Committee on the Indigenous and Northern Affairs that are gathered here, and yourself, Chair Garneau. It is my pleasure to appear before you to speak on the non-insured health benefits program. I'm joining this committee presentation today from Treaty 6, as I stated previously. I'm David Pratt, Vice Chief for the Federation of Sovereign Indigenous Nations in Saskatchewan, and I'm the Saskatchewan representative on the Chiefs Committee on Health at the Assembly of First Nations. I'm presenting today on behalf of the Assembly of First Nations, and I would like to thank this committee for taking the time to explore the matter of great importance to First Nations communities, and that's the non-insured health benefits program. It's consistently been identified as an irritant for First Nations and a high priority area for AFN advocacy and transformation. The NIHB program is perhaps the most frequently cited grievance related to federal health programs and has many factors, including inadequate coverage, lack of timely access, inconsistent adjudication of claims, and burdensome administrative cases. The FN notes that the NIHB program remains primarily concerned with cost containment rather than providing adequate and timely medical benefits and services to First Nations. As you are likely aware, there is an AFN-FNIHB joint review of the NIHB program. The pandemic has stalled some of the progress of this important work, but we look forward to continuing to move forward with this review to make the meaningful changes together. For First Nations, NIHB can be seen as a bureaucratic and intimidating entity. Our NIHB navigators work tirelessly in every region and are a source of immense support, and we thank them for their service. They are the front lines working with families to navigate the overwhelming system, dealing with the consequences of national policies and guidelines at the grassroots level, and this work can be challenging, to be sure. It is critical to note that First Nations are very clear that the NIHB program is funded in the federal fiduciary responsibility based on guarantees through treaty. Our elders teach us that treaties between the First Nations and the Crown are an articulation of the Creator's gifts and wisdom. They are sacred in addition. The treaties articulate relationships and ongoing legal obligations. In the case of health, treaties reaffirm First Nations jurisdiction over their own healthcare systems and establish the positive obligation on the Crown to provide medicines and protection. Crown treaty obligations are founded both in verbal commitments and in the text of the treaties. To be clear, the FN is not a rights holder. Individual First Nations and citizens hold these rights. However, the FN does play an important role in advocating with First Nations for these rights to be upheld. We know from lived experience that the health status of First Nations is far below our national potential, given the financial resources and health system capacity in Canada. In essence, it means that we interact with the healthcare system more frequently throughout our lifespan than other Canadians. Numerous national and regional reports from RCAP in '96, the TRC calls to action in 2015, and the MMIWG calls to justice in 2019 have confirmed that the mental, physical, and spiritual health of First Nations are severely compromised by policy obstacles and constraints, disjointed jurisdiction, proximity to services, and overt racism in healthcare and justice systems. NIHB was constructed to be the payer of last resort, but for many First Nations, this is their only option. And for that reason, we must offer remedies that address the operational and systemic deficits within this program. From what we've seen here, the administrative challenges of the NIHB program have been cumbersome with the burden carried by our citizens. Reimbursements from NIHB to service providers is rife with delay and denials. Service providers are dropping out of the NIHB program at an alarming rate. And to First Nations who may have already have trouble finding a service provider, it becomes even more of a challenge to find care when dentists and optometrists refuse to deal with NIHB anymore. For those who do stay on frustrated with the NIHB program payment delays, more and more service providers are expecting upfront payments from our people. This is an incredible burden on our citizens, particularly elders and others on a fixed or limited income. It can result in people having to decide between food, shelter, or essential medical needs. This places them in danger of compromising their mental and physical health outcomes even more. I would like to touch on related concerns regarding healthcare for First Nations. The COVID-19 pandemic has aggravated existing health and social inequities, and today we see and hear of the multiple and concurrent gaps that affect people's ability to find culturally appropriate supports for their mental wellness and or addictions issues. Systemic racism is another issue which leads to our people receiving substandard care, sometimes death, as was the case with Joyce Echaquan. Systemic racism leads to our people delaying seeking of care from health service providers. Then their health may deteriorate to the point where mostly costly intervention is required and time away from home is extended. Maternal and child health, along with reproductive health services, were placed under a microscope when news of the forced sterilization of Indigenous women and girls was revealed. This criminal practice demonstrates the deeply embedded racist views of some medical professionals. Forced sterilization is yet another act of genocide against First Nations. At present, NIHB does not cover costs associated with supports for these women, nor are their fertility needs calculated into the benefits. Currently, the Western health system is failing our people, and many are returning to traditional healing to add vigor to health regimes. Traditional and spiritual counselors and healers need to be properly recognized and fairly compensated, and it should not be up to the federal civil servants to determine who or what are eligible expenses when this should clearly be guided by First Nations ourselves. Moving forward, NIHB funding must be matched to health needs on an ongoing cycle to ensure sustainability of the program. A long-term strategy must be developed for funding promised on realistic expenditures and utilization projections. This includes population growth, aging projections, inflation trends, and an annual escalator attributable to utilization, new treatments, changes in the delivery of health services, geography, as well as other factors. We also recommend that the Government of Canada support through policy and funding the formal inclusion of the traditional healing of the NIHB program. This process, like all decisions, must be led by First Nations for First Nations. The systemic failures of the NIHB program continue to occur because there is very little accountability to First Nations. And as such, we need reliable and credible data presented in a meaningful way so we can assess the cumulative deficits and construct policy solutions. We welcome continued engagement and encourage collaborative efforts to address concerns with the NIHB program. Together, we hope to reform and realign wellness programs and services according to First Nations priorities that do not place continued restrictions on our health as the NIHB administrative process seems to do. Our people deserve better. As stated in the United Nations Declaration on the Rights of Indigenous Peoples Act,
Thank you, Vice
21,
Chief. We have to wrap up now.
All right, our people have the right to improved health outcomes. Thank you, Mr. Chair.
Thank you, Vice Chief Pratt. We'll now go to the first round of questions, each lasting 6 minutes, and we'll start with Mr. Viersen.
Well, thank you, Mr. Chair, and I want to thank the witnesses for being here. Many of them I've gotten to know, particularly Natan. Welcome, got to know him over the last few years for sure. This is an important study. I know that whenever the government is dealing with healthcare or intrusion into, well, intrusion, not necessarily intrusion, but the caretaking of individual lives, we must always tread carefully. The government must tread carefully, as we've seen with the residential schools situation in the past. Here we are again with a large government institution that is trying to manage the day-to-day lives of individuals. And so I want to thank the witnesses for their testimony on this important topic. One of the things coming from Northern Alberta, representing 14 First Nations, is just around access. That access to health care is a big challenge, and I want to commend the individual nations for they all have a system of transport, and I'm just wondering. I'll start with Natan in particular, just around how in his region getting to healthcare facilities, how does that work? Is that a challenge, and is there areas that need to be worked on around that? Because I would know that in Northern Alberta, there's these big white Ford vans. They say the one I'm thinking of in particular says drift pile medical transport on the side of it, and I see it regularly coming through Barhead, my hometown, bring folks to their healthcare appointments. It's not just to the hospital. Like we have the ambulance for that, but this brings you to your everyday medical appointments that you would have. Natan, I'm just wondering if you could elaborate a little bit about your neck of the woods, how that works over there.
Thank you, Mr. Viersen, for that question. And it has been good to get to know you over the last 6 years. A lot to do with Indigenous and Inuit issues. This is a point of contention within the NIHB program for Inuit, and it's about the way in which decisions are made. And often decisions made in relation to medical transportation are not happening in real time, and sometimes people can experience weeks or months of delays in being approved for medical transportation or for escorts, people that can help the patient get to care. This is vitally important because of where the care happens. There are 51 Inuit Nunangat communities, and just about each one of these communities don't have access to roads to the south. So Inuvik in the northwest and Tuktoyaktuk in the Northwest Territories technically have southern road access, but medical care doesn't flow through that road access. It still flows through flights to Yellowknife and then to Edmonton largely. If people are in urgent need of care and need help to get to that care, the NIHB program can be a lifeline to ensure that culturally safe and immediate care happens, especially in the language of choice of the recipient of care. Sometimes there are programs within the province or territory that interact with the NIHB program about medical transportation, but too often we are hearing complaints from Inuit about either not being given clear decisions or being denied either medical transportation or escorts within medical transportation. And this really is at the crux of what we can do.
Would you have a fairly specific recommendation around transportation? Like
the specific recommendation would be that
this is
within the delivery of NIHB.
Somebody, well, yeah, but is it around the ability to take an escort along? Is that really where the crux is of the problem, or?
I think that for the solution that we would be looking for, it would be a model within NHB that is Inuit specific, that's distinctions based, that also has particular timelines for decision making, and then clear links to the service delivery provision within the region.
Ms. Caron, I'm not sure if you're still there. It's just your camera went up. Oh, there.
I'm here. I just had to move. Right. Sorry.
You have 30 seconds, Mr. Viersen. 30 seconds.
Oh, well, then in that case, I will just recognize just some of the hardworking Métis people of northern Alberta and then Saskatchewan. In particular, I just want to recognize how many of them work in the resource sector in the oil patch in my neck of the woods, and are still frustrated by having to pay the carbon tax and just the travel to get to medical appointments, and the carbon tax adding an increased burden on that. You can confirm that, or I probably used up all of my time at this point already. So thank you.
Thank you, Mr. Viersen. We'll now go to Ms. Atwin. Ms. Atwin, you have 6 minutes.
Thank you, Mr. Chair, and thank you to all of our witnesses. And today I'm speaking to you on the unceded traditional territory of the Wolastoq-Gaoyog here in Fredericton, New Brunswick. I wanted to begin as well by congratulating you, President Caron, for being the first woman to represent the Métis National Council and for bringing women's voices in general to this really important discussion. I wanted to ask, with the signing of the 2017 Canadian Métis Accord, I understand that NIHB has begun to transfer funding for distinctions-based Métis-specific programming. How is this process going?
So we have a lot of work to do within the Métis National Council, and thank you for your kind comments. We've rapidly progressed since signing the Canada Métis Nation Accord, where we were really left out of a lot of different processes. We didn't have any established mechanisms to negotiate different policies or programs with the federal government. We still struggle to implement these programs into our communities due to a lack of infrastructure. A lack of infrastructure and a lack of capacity. Just throwing money at us to just all of a sudden deliver programs and services to our people is fantastic. However, we've all at the same time had to develop our capacity and our infrastructure to be able to do so. So it's kind of, we've been playing catch up and delivering these services all at the same time. The work of the governing members, our Métis governments, is just absolutely incredible. They are up to the challenge in doing all of that work. However, there was an established program specifically for Métis people.
Thank you very much. And just, what would some key pillars be to the ideal model that would best serve your nation? Just it's kind of specific, but if you could kind of give some key themes, that would be really great.
For sure. So, we have already started having these different conversations and have actually just wrapped up developing the Métis Nation's vision for health. And it's a healthcare framework that is largely the beginning of the process that the government is going to be doing in developing the distinctions-based healthcare legislation. And so we got to work in consulting with our communities to find out exactly what is needed for healthcare with Métis people. And the biggest thing that we have is that it has to be holistic, and that healthcare needs to encompass all of the social determinants of health. We make sure that we have conversations even around how climate change is affecting the healthcare of the health of our people. And so the biggest theme that is in our vision for health is ensuring that it is holistic and takes into consideration all of the different social determinants of health that is affecting our people.
Excellent. And how much time do I have, Mr. Chair?
2 minutes and 45 seconds.
Perfect, thanks. I'll turn to Vice Chief Pratt, if I could. I understand that there's an ongoing review of the benefits that are being co-led by the AFN. And this has resulted in funding from Budget 2017 that had coverage for mental health counseling provided by traditional healers. What has this meant for communities, and are there other areas in healthcare where solutions like this could be implemented? Mental health is very close to my heart, so I'd love to hear how this is working.
Thank you. Can you hear me all right? All right, thank you. Thank you for the question. First of all, of course, First Nations, we had our own healthcare system here prior to contact. We relied on a lot of our spiritual and traditional healers. We still do. A lot of our First Nations people utilize both systems of care, whether when they're being treated for cancer, but they also take our traditional medicines and healers, and it's worked for a number of them. So our position here in Saskatchewan, and as well as many of the other regions, is that our healers and our elders have to be a part of the system. They bring such knowledge, and I know that they've helped a number of our people. And one thing we know for sure is that the Western system, with all due respect to our European brothers and sisters, the Western system of treatment, whether for addictions or mental health services, does not work. First Nations have to drive it. It has to be holistic. It has to be based not only on the spiritual connection, the mental and emotional, but even the connection to the land is so important. So there's some great things happening on the ground here with a lot of our traditional healers and them being incorporated, but non-insured health benefits has to properly respect them and also give them that same level as a person with a medical degree or a person with a PhD in psychology. So that's key and that's critical as a part of this long-term reform that we're talking about today. Hope that answers your question, Senator. Yeah.
Thank you very much.
Yeah, thank you.
You've got a minute.
Okay, perfect. So you also mentioned, Joyce Etchikon, and the need for Joyce's principle in particular to be implemented across healthcare for Indigenous peoples. Just if you could speak more about that and some of the systemic racism and how that impacts healthcare delivery for your communities.
Well, oh my goodness, we have. At the FSN, and I'm sure the other regions is too, we have literally stacks of reports. And of course, recently the federal government committed to a First Nations health ombudsperson. That work's starting, but there's just there's encouraging news in Saskatchewan. Over 70% of the healthcare professionals in a survey by Saskatchewan Health Authority recognize we need to do more for First Nations health, recognize that we have to implement the TRC recommendations specifically for healthcare. There's just that 30% that hold the systemic and institutional racism that's impacting our people's health. We're dealing with cases right now, but there's lots that has to happen. And I think that as we move forward on this transformative work on NIHB, it can address some of those inequities and those discriminatory practices and hold the system accountable to our people when they walk through the doors of those emergency rooms and clinics.
Merci beaucoup. On va passer à
We'll now go to Ms. Gill. You have 6 minutes. Thank you very much, Chair, and thank you to all the witnesses for their presentations before the committee today. It's very important to hear what you have to say on the non-insured health benefits First of all, first question to Mr. Pratt. As you mentioned in your statement, you participated in the joint review in 2015. And I'd like to know, well, that'll be 5 years ago, of course, what improvements were brought to the system, in your opinion, and I'd like to know what your thoughts are on what is left to be done and perhaps prioritize them.
For the question. And first of all, I just want to say that that work is continuing and ongoing right now. It's a work in progress. There was some movement on that, but of course, the pandemic kind of put the brakes on everything when it came to that very important work that we're conducting right now. I know that in terms of changes, there is a lot of the good conversations that have happened with Canada, where they were hearing the concerns from each of the regions. In terms of the implementation, I think we still have a lot of work to do. So that joint task force has to continue their work, and that'll be a priority at the AFN as we're moving forward, especially now that we're coming out of the pandemic. We want to be able to continue to make sure that all the issues are being heard from all the 10 regions in Canada, so that that very important transformative work can happen. And I want to acknowledge our health navigators in each of the regions, because they do tremendous work. Like here, I can not only speak on behalf of FSN, but the other regions too as well. When there's an issue, I'll bring it up. They elevate it. They deal with NIHB. The denials are reversed many times in a lot of cases, particularly with elders. As I said in our statement, we had one elder that had to choose between paying her rent and paying for her dentures, because NIHB only pays for dentures every 5 years. So we got some advocacy going. She paid for her dentures because she couldn't eat without them, obviously. And they reimbursed her and she was able to meet rent. So those are just some of the prime examples. A lot of First Nations people rely on this program. We have to make sure that it's sustainable. Number one, we have a booming population, but number two, we have to make sure that it meets all the needs that the Crown agreed to when we signed treaty, particularly the medicine chest clause of Treaty Number 6. Miigwech.
Merci, Monsieur Pratt.
Thank you, Mr. Pratt. Now, if I were to summarize, following this review, the task force, consultations occurred, of course, but difficulties with implementation. Obviously, the pandemic was an issue, but perhaps between 2017 to 2020, that was 3 years, so I would have liked to have seen some concrete advances. I'd also like to know from the witnesses on an issue that's of interest to us within the scope of this current study, Call to Action 22. Ms. Atquin talked to it a moment ago. I've followed the work of the Commission. I wasn't privy to all the conversations, of course, but perhaps you might explain to us or define for us what you mean by traditional counselors. I'm sure it's different from different communities. And how would they work within the community and with perhaps the conventional medical services as well? How would their work be recognized, officially recognized and appreciated? I know I don't have much time, so perhaps you might tell us what traditional advisors and counselors do. Thank you.
How much time do I have, Mr. Chair? 30 seconds or so?
You have 2 minutes.
2 minutes, okay. I'll try to get it under 45 seconds. All right. First of all, thank you, Senator, for that question. And I do want to say that the traditional healers, the elders in our First Nations communities do a lot of great work that's recognized. I know that they've done some excellent work in terms of healing. I don't want to share too much stories here because there's not enough time, the time factor, but there are numerous occasions where the traditional healers and elders have gotten involved.
Je peux vous interrompre, Monsieur.
I don't want to interrupt you, Mr. Pratt. I know it's really tough to work under this time limits all the time. But if you can, and if you would, you can send us some more details in writing after this committee. Thank you.
Sure, Senator, I'd be happy to. The AFN will prepare a brief note for the committee, and we'll forward those more information on them. And I really appreciate that you're interested in that. It shows that there's some interest in terms of our traditional medicines and our traditional ways and our elders. And we'd be happy to provide that to you with a follow-up to this committee. Thank you, Mr. Chair.
You're welcome. Bon, alors nous allons aller maintenant à Madame.
We'll go to.
Ilon na se tunga suktit tumabasse koyan na me onik tiaktuin na ugase taman na pimagerong man kauye mayuin na ko kata amisuit no nakakak si mayuit akilaktok daw na tik ikayokto katang mat.
We know that many Aboriginal people are volunteer medical escorts when people have to travel south. The medical escorts are usually volunteers without pay. The escorts volunteer, they leave their families behind, they leave their children behind, and sometimes they may be away from their family for up to a month. Can you answer? For instance, Cassidy, I'll ask you first, Nathan, and then David. The medical escorts make a big difference to the patient. They are volunteers. I would like to see them paid as medical escorts. That's my first question.
People don't have access to NIHB. And so we have been developing our own medical transport systems on our own in each of our governing members for quite some time now. And it's based on various contribution agreements that we get through federal government, provincial government, territorial government, and sometimes even just applying for grants through non-for-profit organizations. So as a specific example, Métis Nation Saskatchewan has set up their own medical transportation system from northern communities to the south. I don't have the actual stats on there. If they do pay their support people who travel, that is something that I'll have to look into, but you're absolutely right. I mean, the family members who travel with our community members down south to access health services have to put their lives on pause to be able to support their family member or their friend who needs to access health services. And I think that if we can honor their time in ways that they're not being honored right now, it would be very beneficial.
This dovetails into official language rights and official language status. Inuktitut has no federal status as an official language and doesn't have status even as an official language in Inuit Nunangat by the federal government. It has official language status within 3 of the 4 Inuit jurisdictions, and therefore services that are provided by provincial or territorial governments sometimes can be delivered as a right in Inuktitut. But largely medical escorts are also providing interpretation services. And we need a greater recognition of Inuktitut within the way the federal government provides service delivery to Canadians to ensure that these services are not given by family members or people who have no training within the medical field, but are actually providing services on behalf of a health system and patients. I think that some of the roles that escorts play are medical system roles, and when those roles are provided, there should be a real clear understanding and focus by health systems about the compensation necessary in the provision of health services.
Hello, thank you, Senator, for that question. And first of all, I just want to acknowledge that medical transportation does have a lot of challenges, even in Saskatchewan. A number of our people have come forward, of course, with the rising costs of gasoline now. The mileage is inadequate for them to be able to get somewhere to meet the needs of our people when they're particularly transporting our people. For an example, I'll say for dialysis treatment, of course, diabetes is very prevalent amongst First Nations people. We're not built for this Western diet of Big Macs and fast food and processed foods that are sold at the Northern store. That's where, you know, we're off that diet now. It's impacting the health and welfare of our people. And medical transportation is a big issue. You talked about the language, I believe, Senator, in terms of the challenges. Language barrier is huge, particularly for our northern and remote communities. For example, the Dene communities, we had an elder that was sick in one of our hospitals, the Victoria Hospital in Prince Albert, and could not communicate with the doctors and the nurses. And it was simple as them reaching out to the local tribal council and say, hey, we need a Dene speaker in here. It was a Dene nurse who was working on call in a shift that said, hey, this elder needs this and this and this. And he finally started getting the treatment that he got. In terms of the families being there to be able to provide those supports, yes, it's inadequate. I do want to acknowledge NIHB, but they do need to bring up their hotel rates. Some of the hotels that they keep the families at, they're inadequate. They're not. I would not stay there. I would not keep my family there, but because of the amount or the ceiling cap on paying for the hotels, they're putting them at hotels that they shouldn't be staying at, particularly when we did sign treaties and agreed to share the wealth of this land. When our people are sick and they're suffering and they need supports, they shouldn't be staying at a rundown hotel with barely getting the gas that they need to get to support their family member. So lots of issues. We need major investments and we need sustainability. Thank you.
Thank you very much. That'll bring the first round to an end. We've got time for a short second round if everybody is disciplined. And so we'll start with Mr. Vidal. You have 5 minutes.
Thank you, Mr. Chair. And I want to thank the witnesses, all of you, for being here today. I have to admit, I'm a little bit surprised how much discussion we've had about medical transportation today. I thought that would be kind of a more peripheral topic today, and I wanted to focus a couple of my questions with Vice Chief Pratt on exactly that topic. He's very familiar, obviously, with my riding in northern Saskatchewan, as he just referred to some of the rising costs and the challenges. So I'm just going to change it up a little bit to drill into some comments that he made. He talked about the review of the NIHB program and some of that going on. He also talked, Vice Chief, he talked about service providers dropping out at rapid rates, and I know you referred to dental and optometry, but I want to tie that back to travel for a second, because just before all of this study began, I actually had some people reaching out to my office about their concerns about trying to survive in the medical taxi business from northern Saskatchewan. So in the context of the review, you referred to the high costs, some of the, cost of fuel, et cetera, et cetera. In that review, is there any discussion going on in how we ensure that we don't lose those service providers that are providing some of the transport as well? Or is that becoming an issue in Saskatchewan that you're aware of?
Right, thank you, Gary. First of all, it's good to see you virtually, and we haven't connected in person for a while, obviously due to the pandemic. Appreciate that question. Yes, in terms of your questions, yes, there is issues around the medical transportation, particularly for the north. Dialysis treatment is a prime example, Gary, and you're riding, well, the highways, the distance from First Nations communities. They have to drive sometimes 5 hours one way to receive the dialysis treatment in North Battleford, and that's a long way, Prince Albert and Saskatoon. So 5 to 7 hours one way. And of course, when they come off the treatment, they're weak and, they're not well, then they got to drive back 5 to 7 hours again. So it takes a lot out of our elders. So we have access to those treatment facilities closer. But yes, there is an issue on medical transportation, Gary. That's a huge flag in terms of providing and meeting the needs and the challenges, particularly for our region. And I can't remember your second point, Gary.
That's fine. You know what? I'm going to, just because we're so limited time, I'm going to move on to another one. I'll give you a pass on that one, okay?
Okay,
so
thanks.
The other thing I wanted to talk about a little bit today is mental health and some of the stuff around that. And you and I have had conversations in the past about this, and I just want to drill into a couple things. As you're well aware, one of my first experiences as a member of Parliament back in 2019 was experiencing the declaration of a state of emergency in one of the First Nations in my riding. Shortly after that, there was an announcement of some funding, and I was actually privileged to be president in Saskatoon when that was, you and I were there together. And there's little information that I'm able to find on kind of how the department measures or evaluates the performance of these kinds of I don't know if ad hoc investment is the right, but it was something that was a reaction to a situation at the time. I'm just curious if you can shed any light on the impact that funding over 2 years had, how it gets measured, how the money got spent, how many First Nations in Saskatchewan were impacted by that announcement from, I think that was December of 2019, if I'm not mistaken. I think you'd be very familiar with that.
Yeah, thanks, Gary. I'll be real quick with my remarks. I don't know why I'm getting feedback here, but definitely yes, the 2.5 million, and that was in a result of Ochapwace First Nation, Chief Margaret Bear, as well as Chief Ronald Mitswing and Makwasahagan, which is in your riding, Gary, declaring states of emergency. And that happened right during the AGA that year, that December, when they had a number of suicides. And these weren't just young people, these were older men. But right now in Saskatchewan region, committee members, we are in a full-blown addictions to crystal meth and fentanyl overdoses and a mental health crisis. And it's really bad out here, as I'm sure it is in all the other regions. You're hearing the reports of overdoses. There's an overdose every day. Somebody's dying every day in Saskatchewan, maybe 2 or 3 times a day with an overdose to fentanyl or crystal meth. Plus, and you have that exacerbated by the pandemic and the isolation for 2 years. Of course, addictions have risen up, mental health have risen up. But Gary, that 2.5 million, 2 million flowed directly to, we knew 2 million wasn't enough. It was a drop in the bucket for what we needed in Saskatchewan. So what we did, we didn't want to be the judge and jury like Solomon, dividing which part should go or who should have it. We just decided, break it up. We have our funding formula that we use for SIGA, bust it all up by population, get the money out the doors. And there was some good work that came of that. I'll give you an example. We gave, I think Peter Ballantyne, one of our largest bands, again in your riding, put on a youth event for 3 or 4 days for their young people because they were experiencing a crisis. A 10-year-old girl killed herself in South End, and it kind of spurred the First Nation, the chief and council, bring their youth together. We were able to take 150,000, which was their allocation out of the 2 million, and put on a 4-day event and bring their youth to Saskatoon and build them up and teach them, coping mechanisms. They did the assist training. They were able to how to talk to one another on how to prevent people taking their own lives. So there were some good outcomes that came out of that. But Gary, committee members, we need more, and not just in Saskatchewan. We have a comprehensive life promotion program ready to go. We just need the funding. And I think we could probably speak the same for all the regions. We are in a full-blown mental health crisis. We need those investments and those resources across the board. So thank you very much. I'll keep it at that. Yeah.
Thank you, Mr. Pratt. Mr. Pawlowski, you have 5 minutes.
Well, following on totally with that, to Mr. Pratt and our Chief Pratt, having worked for quite a few years as a doctor, including a couple of years in Norway House, I would totally agree with you that the European healthcare system has totally failed in mental health and addiction. Implementation, but in an approach which really has not worked well in Indigenous communities. I would also suggest that our present system isn't very cost efficient, because when you have to fly somebody out of a community after they've overdosed, you have to pay $30,000 or something. But that $30,000 would be much better spent to provide the services in the communities. And I agree with you that we should be doing way more in terms of funding Indigenous healers within the communities, people that are far more likely to be successful than people with a purely Western European approach to mental health problems. Are we doing are we doing enough in terms of mental health services in the communities? And it sounds like you're from an area where there's a lot of isolated communities. Do most of those isolated communities have any mental health services on an ongoing basis, and especially with the traditional component?
Thank you for that question, Senator. There is, and the sad part about it is when, like you said, the Western way, when there's a crisis in a community and the community declares a state of emergency over a mental health issue, whether it's a string of suicides with youth or overdoses, and they bring in this community supports, Canada or ISC or FNIB will bring in those counselors, well, those therapists to provide the wraparound supports for 3-5 days, maybe 2 weeks. They're in there, but then it starts taking a toll on them. When Makwa declared the state of emergency, they had to replace the mental health workers because they were burning out, carrying all the burdens of the community and the people. So in terms of traditional ways of knowing, I think that's where we could look at what INAN's doing with the Choose Life program in their northern nations in Ontario. That program's working. It's all land-based. It's all connected to the land. And I think we need to look at that same approach here in Saskatchewan. There's a lot of people going back to the land and realizing that there is healing in nature and building that reconnection that First Nations people have always had for thousands and thousands of years here on Turtle Island. And I think we need to restore that and look at those. The Western model is not working. Let's try the First Nations way and see if that helps. Because we know something. If the current system is failing, let's try something new. That's my recommendation. Yeah. Miigwech.
Does that NAN program have funding from NIHB, and would they be willing to finance something similar in your communities?
I don't think they may use them, like if there's a attempt or they provide the individuals if they're not successful with the wraparound supports that they need. But I believe the Choose Life program was funded by ISC and partially by First Nations Indian Health Branch. But I believe now they're using prevention program to create these life centers in each of their First Nations. I don't want to speak on behalf of my good friend Chief Derek Fox, but I do recognize a good program that's working for them. And I think we need to look at that and incorporate it all across our regions. And I think we'll see the numbers come down and we'll be able to provide those supports to each of our member nations.
Hopefully quickly, you talked about people opting out of NIHB, and I can certainly see people might get frustrated having to deal with the bureaucracy and getting paid through NIHB, but doctors aren't allowed to opt out of the publicly funded healthcare system. Should people be allowed to opt out of the NIHB?
I don't think so, because I'll give you an example here right now. Some optometrists in Saskatchewan region, give you one example. They're no longer taking NIHB. People have to prepay, and then they have to submit their receipts to NIHB because the optometrist will no longer submit for them. So that's just one example of a broken system that needs to be fixed.
So would you agree that perhaps we shouldn't allow people to opt out of NIHB?
No, I don't think people should be allowed to opt out of NIHB, but also a lot of times they look at our own independent job service health programs first before they even go to NIHB as a last resort. So because of the challenges of getting paid, I guess, or whatever the issues are there, but the system needs reform, and I believe we can fix it if we work together on it. But the bureaucrats need to step back and listen to the experts on the ground that know the issues that are going on with First Nations people. Miigwech, Senator.
Well, if any time, Nathan, do you have any response in terms of allowing people to opt out of NIHB?
Thanks for the question. This is one of the great concerns about the way in which NIHB is delivered across Inuit Nunangat and across Canada for eligible Inuit, and I would imagine the same for First Nations and Métis. Depending upon the service provider, you might have to pay up front, maybe the pharmacy, maybe at the optometrist, maybe at the dentist. And then in other cases, there is a wraparound system. So the client, the person who is eligible for a service, doesn't have to pay any upfront costs, and the system takes care of that. It depends upon where you are in the country. And that is entirely inequitable, especially when we're dealing with a population that has such poverty. as the Inuit population in relation to other Canadians. Sometimes Inuit don't have credit cards, don't have methods of payment. And so therefore, if they're in a setting where they would have to pay for their dentist or their glasses out of pocket, that is a huge barrier to access healthcare and healthcare that they are eligible for. And that is entirely inequitable. And I believe that this program should be reformed to ensure that those types of scenarios don't happen.
Merci beaucoup. Nous allons aller à
We're going to go to Ms. Gill, 2.5 minutes. Thank you, Chair. I asked an earlier question as to traditional healers, and Mr. Pratt was very kind in responding. I would have liked to hear from Mr. Obed and Ms. Caron as well for their specific contexts. So I will do that, and I will let them speak.
Yes, I believe this was in relation to traditional counselors. There are many different types of mental health services that can help an individual. And from an Inuit perspective, there are clinical mental health services that some Inuit may need. And then there are more traditional or culturally specific mental health supports and services that Inuit need. Those two systems can live together and support one another in a diagnosis and in treatment. In many cases, the decision-making about the cost for those, the decision-making around whether or not an individual is eligible has not been equitable. We are seeing the federal government recognize Inuit cultural and technical mental health supports in a much broader way than we have prior to the Indian Residential School Settlement Agreement and the programs that were mandated out of that particular settlement. We have seen now over a decade of Inuit-specific mental health supports and services being provided through federal funds that have helped thousands of Inuit. We hope that the NIHB program can seamlessly accept that types of mental health supports alongside of clinical supports.
Thank you. Et Madame Caron, est-ce que vous avez des commentaires?
Madame Caron, would you have any answer?
Yeah, so there's a lot of Métis health researchers across the Métis homeland right now, and they're doing a lot of looking into and researching access to health services for Métis people. And they're looking into different areas, specifically in mental health or other types of services. And largely the number one recommendation that's coming out of those research reports is the need for more Métis healthcare providers. So actual Métis people entering the healthcare profession or mental health care profession to be able to weave our ways of knowing into these systems in ways that work for our people to deliver culturally responsive and culturally safe care to our people. For example, we recently traveled over to Rome to meet with the Pope. We brought a Métis psychotherapist with us. That person has been trained in the Western ways of mental, like clinical psychotherapy. However, being a Métis woman herself and a practitioner of our traditional ways, she weaves those pieces into the systems of working with our people in a way that traditional healthcare systems do not and cannot. And so it largely comes from increasing supports to promote the healthcare profession within our people and within our communities. And I think that's a model that we can look at is extending healthcare providers healthcare education into our communities so that people are more wanting to go towards those paths.
Thank you very much. And we'll conclude with Ms. Idlaud.
Thank you. Thank you for your reply. If you could all respond to me with Nitan first. What do you think of Aboriginal people? Would their lives improve on mental health issues if the Aboriginal councillors were paid like mental health workers and were recognized like mental health workers.
Thank you for the question. Absolutely, the recognition of the services that, in our case, Inuit counselors provides just as much support as the clinical services that provide by non-Indigenous people, and also are just as complex, that rely on just as much knowledge, just that it has been it has been passed down, or the people have learned it in a very different way. So absolutely, much more work needs to be done to ensure pay equity and basic recognition of Inuit counselors.
I have nothing more to add. I absolutely agree with everything President Obed just said within the Métis context.
Thank you for your question, Senator. Totally concur with President Obed. Definitely, we need our people to be recognized. I'll give you an example here. The funded FNIHB non-insured health benefit mental health counselors here in Saskatchewan. There's a list where you have to declare, and then you do your services and you submit billing. There's an example we're dealing with right now with a doctor, with a traditional healer who was listed herself as a psychotherapist prior, but now changed the designation of her position in her practice as a spiritual healer. Well, now because she changed the designation of her title, there's an issue now with FNIB, or non-insured health benefits, not paying her. So we're actually dealing with that right now as we speak, our staff at FSIN. So there are issues around that. We have to, if she had a PhD or a mental health master's, psychologist, boom, no problem, paid right away. But the minute she changed her designation on the NIHB list of qualified mental health therapists, she was denied billing. So an issue, Senator, that has to be addressed. We've got to reform this system, senators, members of parliament. We have to get this right and make sure that our two systems can exist side by side with mutual respect, and not one being higher than the other or recognized as superior. All right, thank you.
Thank you very much, Ms. Laut. And that brings our panel to a close, but I'd like to thank, on behalf of the committee, Vice Chief David Pratt, President Obed, and President Caron for your testimony today, and thank you for answering the questions on our study of the NIHB. You were the kickoff meeting, a very important meeting. We very much appreciate you taking the time to be with us today. Thank you. And we'll now suspend momentarily committee so that we can go in camera and continue with committee business. Thank you very much.
Thank you.